fellow countrymen and women. These are our ministers and permanent secretaries at the front bench, representing the various ministries and answering the questions that matter to us. Join the conversation. This is the front bench.
Uganda has joined the rest of the world to commemorate the International World AIDS Day. It is very important here in Uganda. The government is also doing whatever it takes to ensure that by 2030 no more AIDS in Uganda. How best can we achieve this? These are some of the things the senior officials from the Ministry of Health are going to be putting across to you, the viewer, so that you do understand clearly what is on the plate for us Ugandans to consume when it comes to issues concerning health. PS, thank you so much for sparing time. Uganda is committed to ending AIDS as a public health threat by 2030. What does this commitment practically mean for the average Ugandan today?
Thank you very much for that question. Uganda is part of the global community that was part of that commitment that we set at a global stage, but also at a national stage, to reduce or to completely bring down the rate of infection in our country by 2030. And we are still committed to that. What does that mean to any person listening to this message? It means that we have, I would say that, first of all, the public needs to know that HIV is still with us. Secondly, we also need to know that as we go along in the course of this epidemic, because the numbers have come down significantly, people have relaxed. Even when the messages are going out, even when we are trying to remind people that, you know, they need to keep away from HIV, there is a way they have taken HIV as just something that can be manageable, so it is okay. So they are used to that. It is no longer that HIV AIDS that we used to see those days that would scare people, and then, you know, the moment you see someone who is very cachectic and very sick, and you really get scared. But because now we have treatment, we have, you know, people live normal lives, there is a way people don't take it serious. To every Ugandan listening to us, the 1.5 million people in Uganda that we are treating with HIV, that's a big burden for government and partners to continue treating. And because this is a lifelong therapy, the commitment of treatment is huge. So what, to the person listening to us today, it means that we need to work with everyone to make sure that we stop that escalation of numbers that add on the list that will demand and require ARVs for their long life, because that is a long-term commitment. That means that we are going to spend still more money if we are negligent and we don't reduce this infection. It has a very serious economic impact. It means that if we want really to reduce this, it cannot be only Ministry of Health. It means that every community, every household, every family, every person on individual level, they have a role to play to contribute to our target of reducing this HIV. Actually, we talk about elimination. Elimination, making sure that, okay, we may not stop the ones that already are, but we don't want to see new infections coming on board. So this is a target we committed to as a country, as a global community. But it takes personal responsibility to contribute to this. We are here to talk about it, and we hope that you take this message seriously. Thank you.
PS, before I cue in the Director General, how do we change the mindset of people? You've talked about how Ugandans think it is no longer as it was before. Probably it is no longer threatening, but it is still a killer disease. How do we change that mindset for Ugandans?
The mindset, definitely, that's why we are here. We are here to talk about it. That's why we commemorate the first day of December, to continue reminding, to resound the message, to tell them that the danger is still with us. To also remind them the routes through which the HIV gets to people. To remind them the effects of HIV on the community. To remind them the effect of the community on a household, on the nation, because right now we are spending so much money to buy medicines for HIV. And so if people need if they know the importance of HIV prevention by changing their mindset, knowing that this is a killer disease, it also incapacitates, it requires long life therapy once you, but also the therapy has its own complications to some people. So it's not a disease that people should not joke about. I know that people are used to it, but it is a killer disease. It is contributing to people getting TB. So it's not just even HIV, but it comes along with other complications. So people need to know that it is their responsibility first, and they change their mind. They change their mindset, especially the young people. Because right now we still see a lot of high infection rates among adolescents. And those adolescents are the ones that even don't check themselves, they don't know their HIV status. Even those that check and they know, they don't start on treatment. Even those ones that start on treatment, they don't adhere to treatment. So today, my emphasis on mindset change, I want really this message to go to adolescents and young people, especially young ladies who are more vulnerable, who are getting the higher percentage of HIV is among the young ladies. So we are here to say, don't take this for granted. Don't think HIV, you are used to hearing it. It is real, it is still existing, it is still spreading, and you can avoid it.
All right, Director General, according to Uganda AIDS Commission, new HIV infections in Uganda have dropped from 96,000, that was in 2010, to 37,000 in 2024. And AIDS deaths from 56,000 to 20,000. That is according to the AIDS Commission. But the question is, where do we stand now? Are we on track to meet the 2030 target, or are we lagging behind?
Okay, thank you for the question. And I also want to share that we are making progress as a country. And I think the statistics you have highlighted already show that the numbers have dropped. If you look at, currently we have 1,530,000 Ugandans living with what? HIV. 94% of them know their HIV status. 90% of them are on treatment. And then of those who are in treatment, 97% of them are virally suppressed. So if you look in terms of the 90-95 targets, it means that we have achieved the last one. And so now it means that we need to look for 150,000 people who still don't know their status and put them to what? Treatment. We reduced the new cases from 100,000 from in 2010 to now 36, 37, as has been highlighted. So you have seen that that's a very big drop. But a 36,000 it means that we're having 100 Ugandans getting infected every day. 100 of them getting what? Infection every day. And 1/3 of them are young people. So you can actually say that almost 33 of those who are getting infected every day are young what? Are young people. So those are the windows now we need to close. For us to be able to end AIDS by 2030, it means that we have to reduce the number of cases and versus the number of deaths. So far, we are having that we need to be able to drop the number of cases. Then we also need to read. So if you look at the deaths, as you have said, they are 26.
Yeah.
So it means that you have to bring the number of new cases also lower than what? Lower than the number of those who are dying. Then it means that you have achieved epidemic what? You have been able to achieve epidemic control. So we still have a task. And as Ugandans, I also want to speak to that. Of the 1,530 cases who are HIV positive, over 961 are women or females, which is almost like 63%, which speaks to what the PS is saying, that the girls are now the ones who are driving the new cases. The remainder is the what? The ones which are males. So the female gender still remains a much more vulnerable what? A vulnerable number. So we are making progress, and I'm sure that if we continue in the direction, but we are not moving at the pace we would have wanted to move.
Director, after having that data that you've told us about, now that takes us to how prepared our health systems are, the workforce, the supply chains to scale up HIV prevention and treatment to the level needed, that is for 2030.
Okay, we have scaled up now, because now almost all our health center-frees are ART centers. So which means that almost every sub-county where there's a health center free, in addition to the health center force and the general hospital and the national hospitals. So treatment is accessible, and we have not had stockouts. The drugs are what? Are available. Both the first line, second line, and the third line. So what we just need is for people to access these medications. So when we had definitely the stopgap measures, we now need to bring in new mechanisms, and that's why we brought integration. Previously, we used to run the chronic care clinics differently, but now we have brought them under one roof, and so that we can be able to use the still available resources to be able to provide care. That does not mean that the ministry is not intending to recruit additional staff. So we plan to recruit additional staff so that we can be able to achieve our target of 55% by 2030.
DG, still with you, before I cue in the PS, UNAIDS released a report recently, and the ED did talk about what is required to ensure that by 2030 we are there. He did talk about the science tools and proven strategies. He says now what is required is that political courage, investing in communities now to prevent all this. Is this really practical?
Exactly, that's practical. If you look at our differentiated care, almost 65% of the patients are now can get their drugs from the one after every 6 months. So they don't need to do what? They don't need to get to the facilities. We have also had, when the time of the lockdown, this is the systems which supported us. The community teams, they were able to do refills for patients who were not able to do one. We also have had where one individual can pick a number of their treatment forward, so you don't need to have all of them come to the facility. So we have all these systems, the community health systems, which we are able to use for what? And now when we get the VHTs available, this should even be able to support it to work much more better.
And also, I think if you look at our strategy as
Yes.
community health, we are now rolling out the CHUs at parish level.
Okay.
And these CHUs are trained in all-round, they are all-rounder. They're able to follow up on people who are having challenges with the adherence of like their medications. They are supposed to link people to care. They are supposed to follow up on other areas, for example, TB, they are the NCDs, they are all-rounders. So it's not, and really we are trying now so hard not to be entangled into individualized disease approaches, because those are the mistakes that we were doing before. We are here to talk about HIV, but at the community level, when our community people are trained, they are trained to make sure that they follow up on all those people. So, as we are trying to end our as we are trying to reach our targets, we want to let the people in the community know that government is committed, first of all, ensuring that their medications are available and they can access the medicines. That's why DG is talking about at Health Center 3s, people are able to access their ARVs. They don't even have to come and queue every month. They can even take a longer period so that we cut out any possibility of someone failing to access. Number 3, we are still encouraging our community people to follow up for linkage, for maintenance, I mean for refill, to continue when those people getting their refill. But also I know that the community was worried about the recent executive order that was signed, and then people were worried that they were access treatment. But as government, even before the Americans came back to us to say we are going to continue, government had already committed that we'll be able, at all costs, we'll be able to take charge of our people. And so there is no reason whatsoever to worry that government will not be able to meet in case our friends said that they are finishing. But that should not worry people. Government is committed. What we need to see now is to get the new infections. These young girls that are harboring a big reservoir of HIV get treated. Because once we initiate everyone who is positive on treatment, then we'll be able to achieve the epidemic or this infection control. Because we will not be getting newer infections. Even under PMTCT, we have lowered significantly the infection that is transmitted from mother to child. I think now the prevalence is much even less than 1%.
P.S. About the medication, DGD talk about the 94% that are aware that they do have the infection. How far with the 2-monthly HIV AIDS injectable treatment? You mean the PrEP one? Yes, that injection you have to receive like 2 months a year.
We are having it. We are getting it in the country, but that injectable is extremely expensive.
Okay.
It cannot be given to everyone who needs it. Well, we are coming up with the criteria, especially the high risk group, and especially the women who the pregnant women, the people who are likely to have issues on adherence. Those are the people will be focusing on. So we have a criteria. It will not be feasible to give everyone that injectable, but as it becomes more accessible, it will be accessible to everyone who needs it. But right now, because we have limited doses, it will not be able to give to everyone.
All right. PS, we are going to be coming back with the police shifts. You will be telling us what you're doing as ministry to prioritize, but also to accelerate to fight against HIV. But allow us to go for a very, very short commercial break. When we do return, we shall be diving deep into the other questions that we did prepare for our audience. Don't go away.
This is the Front Bench.
I don't settle for the surface. I go deeper. At UBC News Tonight, we unpack the story behind the story. We don't chase for views. We pursue facts. The election, the economy, the promises made, and those kept. We ask, we check, we verify. Because the truth should never be a mystery.
The over 40 years of courage, Uganda's journey towards ending HIV/AIDS. In the early 1980s, Uganda's first HIV cases were reported in Rakai and other communities. These first misconceived it as witchcraft until science confirmed it as HIV/AIDS, leading to the launch of a national fight that would span decades. By the late 1980s and 90s, Uganda responded with a bold public education and sensitization program, ABC, abstain, be faithful, or use a condom. This was backed by strong national and community leadership, efforts that drove new infections down and made Uganda a global model in this fight. The 2000 marked a turning point. Uganda scaled up the ARVs therapy, giving hope to millions and turning HIV from a deadly disease into a manageable condition. In 2003, government adopted PEP, an emergency medicine taken to prevent HIV infection after someone may have been exposed. In 2012, Uganda adopted Option B+, providing lifelong treatment for pregnant and breastfeeding mothers, dramatically reducing mother-to-child transmission. In 2016, government introduced PrEP, a preventive medication taken by individuals at ongoing or frequent risk of HIV, such as people with HIV-positive partners, before exposure to prevent infection. Today, Uganda has fewer AIDS-related deaths and millions on treatment, and now a new milestone has arrived, the 6-month HIV prevention injection, giving people at higher risk a powerful new option to stay HIV-free. As we gain confidence in this fight, our health system is also evolving. Government is steadily moving away from standalone HIV clinics and adopting full integration of HIV care into all routine health services. This ensures that people living with HIV receive a complete package of care, from HIV treatment to management of other conditions like hypertension, diabetes, and reproductive health, all under one roof. This approach strengthens privacy, reduces stigma, and gives every patient dignified and comprehensive care for the whole body, not just one condition. But as we move towards elimination, one truth remains: HIV is real and it still exists. Progress must not lead to complacency. Prevention starts with each of us knowing our status, consistently using condoms where advisable, choosing safer sexual behaviors, seeking treatment early, and supporting our young people with accurate information. Uganda's 40-year journey is a story of courage, science, and resilience. Together, we can finish this fight and secure an HIV-free future for the next generation.
These elections matter, and so does how you hear about them. That's why I'm here every night on UBC News Tonight to give you the whole picture and not just the headlines. We report with context, with care, and with commitment, because you deserve the truth. Calmly delivered, clearly explained.
This is the Front Bench.
Well, this is the front bench, ladies and gentlemen. Just to give you a reminder that today Uganda has joined the rest of the world to commemorate the World AIDS International Day. But of course, also to tell you that this program is live on all our 11 radio platforms. So if you cannot watch, at least you can hear and you can listen. That is very important, but also streaming live on our YouTube channel, but also on our X using that hashtag UBC Frontbench. PS, we went for that break. You were talking about the kind of the medication that we do have so far. But let's talk about the policy shifts the ministry has prioritized to accelerate the fight against HIV/AIDS.
The first one is to strengthen health promotion and disease prevention, and also community interventions. And we think that is a big game changer to ensure that we identify the people who are at risk or those that have infection early enough and are linked to care. How are we doing that? We are introducing self-testing. And this self-testing, we are really targeting the people who are more at risk, the key populations, the young people like in institutions, and those who are likely, who are sexually active, but at the same time, they don't have avenue to have regular checks. So we have introduced self-testing and want to encourage anyone who wishes to know their HIV status. These test kits are going to be available even right now in pharmacies. These kits are there. You can go and buy one, and we are going to be putting some test kits in different places where they can even be accessed without people paying, and you can test. So
the fear in people peers, self-testing is very tricky.
No, we have also encouraged them that when they test and they find they are sick, there is a number that they call, and that number will link that person to, first of all, counsel the person, but also link them to care. Because if you hide meat from fire, where do you cook it? So that business of procrastinating that I'm fearing to test, I don't want to know my HIV status. It is not also. I think we need to get away from that, and we are really trying to encourage people to know their HIV status. So first is to completely make a shift and make sure that this information is integrated in all our health messages. So it's not just alone, because we're always having verticalization of everything. If I come here, I should not live here without just talking about even other diseases. So we are talking about HIV, we are talking about diabetes, we are talking about hypertension, we are talking about sickle cell disease that is on the rise because people are not checking when they are going to get married. And we are getting so many babies born with sickle cell. We are talking about other non-communicable diseases, cancers. And so one of our approaches as government and at policy level, we really want to integrate, to have integrated messages, integrated services, integrated community surveillance, so that HIV is, and day-to-day, it's not just one alone pocket issue there. Because I think that also continued to make it, I think that's why we are still dealing with pockets of stigma, because it was always treated, in a pocket somewhere. So that is number one. Number two, we are focusing on getting everyone who is HIV positive start treatment. Before we would wait, until, but now it's test and treat. Test anyone positive, get to treatment, because science has shown that that's the only way we are going to reduce the viremia from, like if I if I am infected and I meet him, I get sexually active with him, if I have high virus in my body, I'll transmit. But if I am on treatment,
okay,
and the viral load is completely low to undetectable levels, it means that even when I am indisciplined and I go after him, there is a higher chance that I will not spread that infection.
okay.
So that is the science we fully know. So our emphasis, our focus is to make sure that everyone who is positive must get on treatment. And if they get on treatment, we must ensure that the people stay on therapy so that they suppress the virus. And I think we are there. DG told us 97 of all our patients who are on treatment now, they have suppressed the virus, meaning that over 1 million people who are on therapy, at the moment they are not, they have low levels of infectivity. But the people now who are transmitting infection right now are these numbers that we are looking for.
Okay. DG, let me cue in. PS, I will get back to you. Talking about treatment now, stockouts of ARVs still occur in some districts. What really causes these gaps, and what is being done to eliminate such issues?
I must say first that as a country, we've not really had major stock out at the central warehouses. The challenges which happen like that is mainly the challenges on aspect of planning. But now what we know that so long as you are tested and you're already in the system, actually your drugs from NMS are ordered based on the numbers which are what?
Submitted.
Which are submitted in the system. The challenges now come if you have to put in new, but also we give allowances in case they are what? New cases. So we've been progressively working on seeing that we reduce stock out. So if there, then it means that probably our estimates, what we say, our quantification in terms of numbers was not correct. But it's not the challenge that the supplies are not available at the major warehouses.
And when it comes to patients really receiving this medicine, that's also an issue, another issue, doctor.
The issues also now which come, because now as you heard from me that now we give patients medicine for 6 months. So probably, so that, and 65% of our patients are all patients who are on differentiated care. They get treatment for one. And partially for all those ones who are suppressing, there is no need for them to keep coming to the facility every other month. The challenges which we have is now we need to be able to see that what's the quality of the data which we have. If we are able to address the quality of data, then we should be able to eliminate aspects of
Actually, that was my next question, Doctor. How accurate is our data today?
Currently, we are still using paper-based records, but most of the time we are now rolling out electronic medical records, and we think that the quality should be able to improve when we roll out electronic medical records. But for now, we have to contend with what's available.
Are we identifying new infections quickly enough, Doctor, to break the transmission chains?
We have mentioned that we need to identify this 150,000
first
people. For us to be able to identify that, the strategy is that you have to test over 5 million people. Because the numbers now are what? Are fewer. So it means that we have to roll out testing to be able to, and for you to be able to identify that, it means that you have to test over 5 million people to be able to identify the 150. And so now that's the reason why we are looking at that. We are looking at what are the high burden districts or by high burden regions. So that's where we're focusing. So the 150,000, we know where they are located. That's how far we have gone. So we are looking at that. We are focusing our tests, not that we are going to test across the country. So the tests now are being focused in those areas which are high burden, which will give us better what? Better yield. So that's...
Doctor, combining all those, talking about how accurate our data is, talking about how do we close the gaps, that is if there is any stock out, that is if in any case, because I mean we're not all perfect, but on the issue of human resource, now after telling Ugandans go and get medicine, we are rolling out a new digital system for that. We are still using some papers, like you said, somehow, somewhere, but of course going digital. The human resource and capacity, do we have enough healthy workers trained in this HIV care, especially in rural areas and high risk areas?
Now HIV is one of those diseases which we have demystified the treatment. Because if it's just a refill, even nurses can do what? Do a refill. It's only when you are not feeling well, that's when you need to see what? To see a health worker. So if we are saying that almost all our health center affiliates are now accredited to offer ART, it means that we have capacity in all up to what? Health center affiliates. So the capacity is there up to the level of what? Health center affiliate. It's only the capacity now we need to improve is to how to manage what? Those who have got advanced disease, or those who are presenting at stage 4, those ones are stage 4, and the majority of them still remain men. They are the ones who are coming to facilities what? Late. Even the separation is still, whereas we have 97%, but men are still having a lower what? Viral separation, because they are not adhering to what? Treatment.
Really?
Yes.
That is serious.
So, but allow me just to add on what he's talking about. I think by and large we've not really had stockouts, really. We have stockouts for malaria, we have stockouts for hypertensive, but for HIV, no, because I think our statistics are relatively accurate, because even when we're still using the manual, they are known. Because these are people who, you know, they keep on coming, the records are there, so even when they are quantifying, that's why we're able to zero down to actual numbers. The capacity of our health workers, HIV has matured. It is not a new disease, it's not like COVID even. It's not, everyone who were in HIV care, how many years? In 1998 when I was treating HIV. And even nurses, and you know, because this is a succulent, it is a succulent area. That's where partners were putting so many everyone, you know, in workshops, training. Everyone is almost having a PhD in HIV care, including the lowest nurse. So the knowledge on HIV is well known. Everyone in this country knows how to treat. But those that come, like for example, in second line, or they have toxicity related to HIV care, the ARVs, because they come also with lactic acidosis, lipodystrophy, and metabolic problems. Those ones are referred to higher care. But refill, those ones, they don't require, for example, a very sophisticated, you know, expert. No, a nurse will just continue giving. If you come and maybe you are not viral suppressing, if they do viral load and it is not coming down, and you are adherent to treatment, then we take the sample. We do HIV resistance, you know, to see whether the virus is resisting the ARVs. If we find that you are resisting, I mean the virus is resisting ART, they send you to a higher facility. They record you, now they registered you to start now on second line. So that's our HIV care is so advanced and so organized over time, because we're working with partners, they invested so much, the systems is there, the structure is there, everybody literally knows how to treat HIV. So it's not really a problem at all on the skill.
Yes, on
the numbers, yes, we still have less. But you see, it's not just only for HIV.
Okay.
Even surgeons, we don't have enough surgeons. Even neurosurgeons, even ophthalmologists, we don't have. Even acute care physicians, we don't have. So it's not just HIV. It is. I think the understaffing is still there, but I think government is committed and is continuously investing money to make sure that we recruit more people.
Talking about investment, actually, I wanted to find out domestic investment in HIV services. According to the UNAIDS report still, I do understand Nigeria, Uganda, Cote d'Ivoire, South Africa and Tanzania are all committed to increasing this kind of investment. But how best are you really focused, appears, to ensure that the national sustainability plan is really in place? Because starting up something is different, but also sustainability.
We are sustaining. From the time we got a executive order, we are sustaining. Even government has released more money and we are buying more supplies. And if they didn't come back to say we are continuing with you, still government was committed to continue buying medicines. Yes, of course, that means that Ministry of Finance would have to suppress some activities and prioritize ART, prioritize lab tests. But I think where we are, I must say that me, I'm very happy. I am not worried that we are not sustaining. We are actually in the sustainability. We are on the roadmap in sustainability. And what we are here for today, as we celebrate World AIDS Day, we are saying, or as much as government is going to continue putting money, committing more resources, committing more human resource, committing more resources to look for those HIV positives that are not on treatment and bring them and link them to care, committed to ensuring that we continue supplying medicines and ensuring that nobody is left behind, including even those key populations. Because at first they were saying, stigma, discrimination, which is really not there. Because everyone who comes to our facilities is treated equally, regardless of what kind of sexual orientation that you may have. So as we continue to do that as government, we know how HIV is spread. We know how to prevent HIV. As we continue investing, as we continue government committing and talking about sustainability plan, we have a cardinal duty individually as Ugandans to make sure that you do not live a reckless life, especially the young people, especially the adolescents, especially like that community that, like sex workers, like all these groups that are vulnerable. Still you can live, you can be vulnerable in society, but you can also avoid HIV. So it is really a responsibility of everyone to ensure that we live responsibly, avoid risk behavior, ensure that we test ourselves with our loved ones. If we know that we're HIV, instead of going into hiding, HIV care is normal. You can get your ARVs, you can live a normal life, you can do whatever you are doing and suppress the viral load in your body and live a normal life. But if you hide, you know HIV, that you have HIV, you are spreading HIV, the infection is growing, then by the time you come to us, your CD4 has dropped, and we cannot reverse sometimes, and then we lose you. That would be catastrophic. The care is available. So as we're talking about all these things of policy and everything, we want, for us here, we came to talk about the common person listening to this message. Do not live a reckless life. young ladies in universities do not allow to be used by sugar daddies. Those sugar daddies that are not taking their ARVs, they are carrying viruses in their bodies and they are giving it to you. Don't accept. Make sure that your partner, you test, because if you sleep with one person, you don't know what that person was doing. So don't be a network. Don't be caught up in the network.
Trust issues now.
Exactly. Don't be caught up in infection somewhere, and then you get HIV, then you give to the other. No, we can stop. We can contribute to you. Imagine if we stopped HIV today, if we really, really lowered HIV. And all this money we are talking about, government is pouring billions of money to buying ARVs. Imagine if really that stopped, that drainage, you know, that is, we are losing money through all that. If we stopped that, do you know the contribution you'll have made for your country to make sure that we save this money, it does something more tangible for your country so that we grow. So you are going to help us to keep safe because you want a developed Uganda. That's why today we are here.
DG, how are you integrating HIV services with TB, maternal health, and non-communicable diseases to improve efficiency?
Integration is, we as a country have really been, integration has been one of our key agendas. Even before the stop-gap measures, we already had started the issues of what? Because we want to do what we call a patient or person-centered care. That this same person could be the same person who is having hypertension, could be having TB, could be pregnant. So we are really integrating so that when you come in, all these issues are done at the same time. And if we do that, then we are able to optimize resources, but also achieve efficiency. And so far as a country and a ministry, we've driven this, and we are seeing already good results. So we really think that we need to strengthen it and be able to see that it's driven by the regions, what we call the regional integrated care systems. So we put systems where the director of the regional hospital, working with the district health officers, they have built their what we call the regional health systems. So we want to see how they are able to support the integration aspect in those areas, so that when a patient comes, it could be HIV, but still it might be she's screened for cancer. It's also looked at because as we are finding now that people are living longer. So we are finding actually that many of the HIV patients, and they are not dying because of HIV, they are dying because of what? Cancer. NCDs. So we really need to be able to screen across the what? In the spectrum.
DG, as we fight all these, what else do Ugandans need to know really? Because we are passing on the message. But are Ugandans putting this into practice? Yes, we do have about 94% of those who understand that they have the virus, they're infectious. PS has talked about one who is infected not to go around playing around with people. But we have those who made up their minds. They're saying, okay, since government is doing whatever it takes to fight this, I mean I can do this. Because if I'm HIV and I'm on medication and my partner may not be HIV positive really.
As I did indicate at some point that the group which is not suppressing are men. So really would want that
to look for men.
The information is to them that if you are on treatment, do what?
Go for treatment.
Yeah.
And for those who do not know their HIV status, go and do what? The tests are now available. We did mention about self-test and the goodness of the self-test. Initially, people were concerned that if we give somebody a self-test, how do we get the results? But I can assure that if you test and you find that yourself you are positive, you cannot remain the same. You will remain restless until when you get what? you get to care.
Actually, we have those who first test. If you realize, for example, Mulago 1 says you have HIV, I first go to Mulago 2 also. I go to Mulago 2 to bring the same results. I go to Mulago 3. I must be sure. There is that fear also.
Yeah, but the issue is that you are delaying yourself because now you would do it.
Now that is the point.
So the issue is that we really would want that you start care, you are suppressing, and then your risk of transmission becomes what? Low. But also your risk of developing optimistic infections becomes what? Low. Because we know that there's a co-infection between HIV and TB. Almost up to 40% of those who are HIV get what? TB. So if you are not suppressing, you will run a risk of getting what? TB. So you'll not only be having HIV, you'll also be having what? TB. But also at the same time, those who are HIV, they are also a risk of developing certain cancers. So you need to, it's a spectrum of what? Of illness. But if you are suppressed, then you are able to avoid all of those challenges. So test is the entry point. Entry point to care is what? Testing. And then adherence to treatment. It's the aspect of if you love yourself, just like us we emphasize for all the other medication. If you love yourself, then adhere to your what? Your treatment. If you love to yourself, go and do what? Test. If you love somebody, then don't transmit what? Infection.
We did lose about 604 billion shillings. That is when U.S. government cut off foreign aid across the world. How best can really Uganda's health sector become self-reliant to end the issue of foreign aid? Now talking about issues health.
I want to ask the PS to...
Yeah, no, it is okay. No, that's okay. PS can throw more light on that.
The thing is, I had mentioned this.
Yes, you did talk about it.
When we got executive order, we sat as government and we looked at what we needed, what we were getting through U.S. government. Because U.S. government was supporting through PEPFAR, then we have also Global Fund and other entities that are coming on board. But you know, because of our systems that were fragmented, we're spending so much money, more than I think what we need. But coming back to your question, government committed, and we went and presented the need to cabinet, and they agreed that they will start looking for finances. And moving forward, I think they've released some money to buy reagents and test kits and some commodities for the population as we are waiting. But good enough also, our friends came back and we are discussing with them to see how we can reignite the discussion of care and also support in all aspects of the three diseases, HIV, TB and malaria. But I must say that in 5 years' time from now, by 2030, I'm very, very confident, without any doubt, that we'll be able to handle our HIV response, our TB response, our malaria response. And I have no doubt, definitely, that we'll be able to handle, because government has committed, and we are going to see more incremental resource allocation for these three diseases. So that, because we've learned, these are good lessons for us. So if we have not learned this time, then we'll never learn.
Sure. Yeah,
for sure. But I must say that we have learned and will not be the same, and we are committed. I just wanted to mention something you asked earlier about what we are doing on
integration, yes.
Now, integration, you know, when we started this conversation, there was this fear that people, groups like key population, what, you know, people will be stigmatized. After implementation, people now have appreciated that there were so many overlaps and so many duplicated and wastage of resources. And now it is very good because we are treating, the concept is treat the person, not the disease. Because before we were treating the disease, HIV clinic, this clinic, this clinic. But now we are treating the person. So we have integrated chronic care. You come, you have HIV, but at the same time you have diabetes. You holistically you are treated. And that way, everybody gets to understand the responsibility and everybody gets to know how to treat everyone, everything. Not like specialized, pocket. So I must say that we are better off now. And even our people spend less time, because now if I come with hepatitis B, but I also I have hypertension, but I have HIV. Those I would require to come 3 times. But now I come once and I get treated and I go with everything, all my medicines, and I go home.
PS, before I go to the DG, he will be giving us his closing remarks. Now I'm asking you now as a doctor, not me as a doctor, but you as a doctor now. Do we have a cure for HIV in Uganda?
The cure? Absolutely not.
Are we thinking about it? It may not be as Uganda, but the whole world at large.
You know, you know, Diana Tini participated in the first clinical trial of HIV.
So the question is the right person.
And when we started this clinical trial, the thinking was that we would get really the vaccine that would deal with both the envelope and the core, you know, of the virus. But because HIV keeps on changing, its nature is simply impossible. It keeps on changing. Because any viral infection, okay, maybe I should have started from there. Any viral infection starts, I mean, you prevent it by immunization. HIV is a virus. The best medicine would be immunize. But because of its nature, that virus is one of the hardest virus to get a vaccine, because it is a highly mutative virus. It keeps on changing. The virus that entered me to now, like 1 hour ago, by end of today, the grandmother, I mean the grandchild of that virus is completely different. So they keep on changing. So even when they are designing the vaccines, that's where it beat us. I think from the time we did Alvac vaccine in 1998 up to today, I think there are about over 200 candidates, clinical trials that have looked at it. But we have not had a vaccine that has given us even up to 60% of immunogenicity. So we have not. But what like, for example, this treatment we are having, its strength is it keeps it. It's like a low. It's a slow. How do I put it? A low releasing, but it is instead it kills. It kills. It's not. It does not just stimulate antibody production against the virus, but it kills. So the cure.
It's not there as
the
yet.
Cure, we don't have 100% cure that you take, and if you have HIV in your body and then you are declared. Right now we don't have any in the country.
The issue of stigmatization, PS, you did mention about it, the misinformation. The public still has a lot of misinformation really about the entire HIV process or the issue that we are talking about. What are you doing? We do have these sex workers, border, we do have the fishermen, the fisherwomen. They're really out there fighting to get this information, but how best do they get
We
that?
we have been actually reaching out. We've been reaching out through different channels, through media, through community interventions, through civil society, through the peer groups. We have people living with HIV. In those groups, among the sex workers, we have people who have been working with them, mobilizing them, getting them tested, getting them vaccinated against even other conditions like mpox, because mpox is also a sexually transmitted disease. So we have the society in those communities. For example, the border borders, we have their leaders within there, especially the people who have HIV. They've formed groups that are actually a big force that is supporting the rest of the people to tell them about prevention, making sure that those that are sick are linked to care, and even the fisher folks. We've been reaching out to all these communities. That's how we've been able to penetrate all those groups and been able to test and make them get linked to care. And that work is ongoing. It's not stopping. It's not like a one-off. It is just continuous.
Okay, PS, I think you will prepare your closing remarks, but let me first go to the DG. As DG, we've talked about AIDS, but of course talking about AIDS doesn't mean we do not have other health issues that we have to rectify as a country. What should every Ugandan do today to contribute to the end of HIV/AIDS? DG, as you give your closing remarks as well.
Thank you for that question. As Ugandans, we have responsibility of our own health care. And if we look at that, we are a neat community, then it means that we are become our neighbor's keeper. So it means that if we want to protect other people, then we need first to be able to see that how do we get to know our what? Our tests. So our HIV status. So we really would want that we need to close the gap. Because if you look at that 94% know their status, I have mentioned the 150. And if you have the 150 and it has a multiplier factor of say 1 or 2,
yes,
that becomes a very big what? So, and that alone has got a very big potential of starting another epidemic of its own what? So the key issue is that if we have to end AIDS by 2030, it means that we need to be able to find those and put them to care, put them to treatment so that they can start, so that they are able to suppress and they are not able to spread infections. So that's what we need to be able to do. For those who are already on care and know their status, we want to thank them for that initiative which they have taken.
Those who know their status, DG, do they go for the medication?
And those who are already on medications would really want that they are there to treatment and continue taking their treatment religiously so that they do want to avoid resistance, because the issue that if they don't take treatment is not just that they don't suppress, but also they can develop resistant what? Resistant HIV, which now you need either the second line or the third line treatment, which is even more expensive than what? The first line. So we really would want that there's testing, there's adherence, but also the aspect of that avoid risk behaviors. Because why should you be able to have multiple partners or those whom you do not know their status, and because you do not know their background, then so you become vulnerable.
That's where trust comes in, DJ. I say, I trust you, me, I've trusted you, so it is upon you.
Okay, the trust, at some point, they reach a point where that you should even not trust your own blood. So if you do not trust your own blood, then you actually should not be able to trust what? Trust
the other person, yes.
The other person. So that's the aspect of it. So that you need to be able to look at that you just need that one single episode, and actually can transform the rest of your what? Of your life. And it can change the trajectory of what? Of your life. So you need to be able to look at, and particularly for the young people. And like I want those ones where their mothers have had empty mother to transmission child. Your mothers invested a lot to make sure that you are born without HIV. And then you abuse or betray this trust which their mothers did. And then now, when you're an adolescent or an adult, you get what? End up by getting HIV.
All right.
So really would want that you remain HIV negative.
Thank you so much, Director, General Health Services, Dr. Charles Olaro. PS, we are winding up. We've talked a lot of issues concerning HIV/AIDS, but you are the Permanent Secretary, Ministry of Health. I do understand there is a lot you would wish as well to tell Ugandans, but of course putting in mind that today we are celebrating that International World AIDS Day, which Uganda is part of.
Yeah, we actually... We are not celebrating AIDS Day.
We are?
We are commemorating.
Okay.
We are simply telling Ugandans HIV is still a serious issue. That's why we set this day, so that every year we remind Ugandans that HIV is still with us. It kills. That HIV has changed its face. I can be looking very nice and I carry HIV. So
I shouldn't judge a book by its cover.
Don't judge anyone by looking very nice. And you know, these days that whether the ladies know how to do makeup and everything, you just see someone doing like this and you're like, oh my God, I can't do without. So HIV is still killing people. HIV has no cure. HIV is, once you get it, that means you will stay on treatment forever. HIV can be avoided by simply avoiding sexual contact with someone you don't know HIV status. You can avoid HIV by avoiding getting blood contamination on your skin, because you don't know who this person, how the blood is. So mothers to child, mothers should attend antenatal. Every mother who gets pregnant, ensure that you attend antenatal, because during antenatal, that's when we test all diseases, including hepatitis, syphilis, HIV, you know, and all other diseases. Then you can have a normal baby. If those that are positive they start on treatment to ensure that their children are born HIV-free, but also on themselves, they make sure that they start HIV drugs. As I conclude, I also want to assure the public that government is continuously investing in healthcare to make sure that you access the services that you need, including the services of HIV. Lastly, the responsibility of national building, of making Uganda grow, achieve her middle income status, achieve first world status. It lies in our hands. How do we do that? We must make sure that we are productive. We must make sure that we are healthy. We avoid reckless behavior. We observe our lifestyle. Avoid alcohol, avoid cigarette, avoid drugs, avoid women you don't know about. Ensure exercise regularly. Ensure that you are active. You don't suffer from non-communicable diseases. Ensure that you sleep in mosquito net to avoid malaria, because malaria is still the biggest killer of our people. Ensure that you clean your homesteads. ensure you avoid poor sanitation around, because 75% of our diseases are out of all these things that we can avoid.
Okay.
That way you'll have contributed to the development of our sweet Uganda. Thank you very much, and we wish you a lovely evening.
Thank you so much, Permanent Secretary Dr. Diana Twine from the Ministry of Health. Thank you so much, Director General Health Services, Dr. Charles Olaro. Ladies and gentlemen, AIDS is still a killer disease, so it is upon you to do whatever it takes to ensure that we fight this disease. Remember, the target is by 2030. I am Jethro Kasaiji. Those who have been listening in from our different radio platforms, thank you so much. Those who have been following the show live on YouTube and our X handle, thank you so much. From me and the entire team, it's a good night.